Hello, good evening. Welcome to this session. 10 important topics from infectious disease. Now, you and me both know that it is very difficult to select out 10 important topics from infectious diseases. It's such a vast and broad subdivision of the internal medicine topics. But let me choose a few which I believe may be asked. I mean, we have discussed a lot in our videos, but I want to stress some of these which you may consider as not important, but may be asked as important in your examination. But it is always better to learn comprehensively. That is something that you will always have to do. We have dealt most of the topics, important topics, as long videos. But if you do not have time, and as last minute kind of revision, you may use these topics. Now, there is both the NEET SS exam as well as the INISS exam. The INISS exam coming in few days, and the NEET SS maybe a few weeks. The pattern is slightly different, but we will basically discuss in point of view from the Harrison's textbook, the 22nd edition. INISS, you may get even difficult questions, core microbiology questions as well. You'll have to prepare that part as well. Now, the first point is that check out the updates. The Harrison's 22nd edition has come, and we have updated the topics based on whatever new has come in the Harrison in ID as well as other topics. The videos are available in the app, and do check out, and you may get some questions from that part. The second point is that pay attention to the tables and figures. Now, we are all lazy, and the examiners are too, and they try to get the questions maximum from the tables and figures in Harrison. This is something that has happened in the last many years in NEET SS. So the tables and the figures are quite important, and do pay attention to them. We have separate videos discussing the tables and the figures. Now, if you look at the general infectious disease, again, I want to just give an example why tables are important. In that first chapter, there are four very, very important tables. I'm not going to discuss all of them, but just understand the importance of tables. So one, discuss the causes of relative bradycardia, which was asked recently, infectious causes of eosinophilia, causes of very high ESR, and CSF picture in different etiologies of meningitis. Now, this happens in like the first chapter, and we may focus on all other important topics, TB, HIV, and all, but the questions can come from these topics as well. So, focus on these introductory chapters also, do not miss them. At least pay attention to the tables in these introductory chapters. A second point, like something that we always misses, is the vaccines. Adult vaccines is a very, very important topic, which can sometimes be asked. Now, there are two topics that comes as introductory chapters on adult vaccination. One is on the categories of vaccines, which we'll discuss, and there is also adult vaccines, contraindications and precautions, with the second table, which you will have to read from Harrison. Now, if you look at this particular table, you can see they have categorized adult vaccinations to the live attenuated, the inactivated, the purified protein-based vaccines, polysaccharide protein conjugates, virus-like particles, replicating viral vectors, non-replicating viral vectors, and the nucleic acid vaccines. Just few examples that can be important. You know the live vaccine, which are the live vaccines. So the live vaccines includes the measles, the mumps, then rubella, that's the MMR, the varicella, which is important. Among the influenza vaccines, the nasal influenza vaccine is a live vaccine, and the oral rotavirus vaccine is also a live vaccine. And remember, yellow fever vaccine is also a live vaccine. So what is the advantage of using a live vaccine? They mimics natural infections, effective in priming with a durable immunity. It's long standing. Okay, but what is the main problem? The main problem is that these are live vaccines. You have to be careful when you're using in certain populations. So they are contraindicated in immunocompromised individuals as well as pregnant females. So that you have to keep in mind. Now, inactivated vaccines, again, these are whole bacteria or viruses which are rendered inactive by chemical processes. So these include the inactivated poliovirus, the hepatitis A virus, etc. Again, so just remember the examples. Then you have subunit vaccines, which uses sub particular proteins or parts of the pathogen that are produced in culture. The example mentioned is the influenza. The new recombinant shingles vaccine, also called as Shingrix, is again a subunit vaccine. Okay, a subunit vaccine of the glycoprotein E of the varicella zoster virus. Then you have the polysaccharide protein conjugate vaccines. Now, there are a lot of polysaccharide vaccines. For example, there is a pneumococcal polysaccharide vaccine. Now, the polysaccharide vaccine has a limited response because it's a T cell independent kind of response. There is limited memory response, so it's not a durable response. Okay, so that is why these polysaccharides, if you are conjugating into a protein, you will have a much more better response, a memory response which can be long standing. So you have the pneumococcal polysaccharide vaccine called as a PPSV23, but it can be conjugated to a protein to make it more immunogenic. So the example is the pneumococcal conjugate vaccine 13, PCV13, as well as PP. We also now have the pneumococcal conjugate vaccine 20, that is PCV20. Some of the vaccines are like virus-like particles. So one or more proteins are arranged closely resemble a virus. The most common example is the human papilloma virus vaccine. Some of the hepatitis B vaccines or the newer vaccines also act as virus-like particles. Then you have replicating viral vectors. So replicating viral vectors means they are viruses which contains the nucleic acid, like of the particular like the vaccine that you want to immunize for, but they will replicate in the human body, but won't cause any diseases. The example will be the Ebola virus. The Ebola virus vaccine called as the vesicular stomatitis virus, Ebola virus vaccine, is an example for a replicating viral vaccine. Then you have non-replicating viral vectors. So the genome, is inserted, uh, nucleic acid is inserted to replication deficient non-pathogenic viruses. The example will be the adenovirus vector-based COVID-19 vaccine. In our country, it was available as the Covishield vaccine. Then you have nucleic acid directly given in lipid nanoparticles. Okay, example will be the COVID-19 mRNA vaccine produced by both Pfizer and Moderna. So this particular table, I just want to emphasize that vaccines, adult vaccines is an important chapter which we often misses. There are two tables, one on the categories of the vaccines. The second is on the contraindications of various vaccines, which is given as a second table. I'm not going to discuss with them. Also understand the difference between polysaccharide vaccines as well as conjugate vaccines. This is given in two chapters in the pneumococcal disease. Okay, that is Streptococcus pneumoniae, chapter called Streptococcus pneumoniae, as well as a figure to explain is given in the chapter of meningococcal diseases. So both these parts you may pay some attention. Infective endocarditis is always a favorite uh, topic that the examiners always has asked. A lot of changes has occurred which we have already discussed when we discussed the updated edition 22. So the important is that the modified Duke criteria is modified again. There has been a change. One of the change that you should pay attention is the change in the typical organism. What organisms has been added to the list of typical organism? Definitely check out that part. Now here I am just discussing one of the treatment options. One of the treatment options for one of the pathogens. The pathogen is Staphylococcus aureus. Now why Staphylococcus aureus? Well, this is the most important bacteria among the gram-positive organisms which you will be asked about. Now if it's endocarditis, infective endocarditis, the treatment options for various organisms are given. For streptococci, that's virulence of streptococci, MSSA, MRSA, enterococci is given as a table. The table is quite important. So if it is MSSA, methicillin sensitive Staphylococcus aureus, what is the antibiotic of choice if it's a inactive valve affecting both right sided and left sided? So here you have to understand that the treatment of choice is either an anti-staphylococcal penicillin, which can be nafcillin, oxacillin, or flucloxacillin. Equally effective, you can use it an alternate agent is the first generation cephalosporin, cefazolin. So this you should remember. MSSA, native valve endocarditis, either anti-staphylococcal penicillin or the first generation cephalosporin. What about MRSA infecting the native valve? If it's an MRSA infecting the native valve, the first drug of choice will be vancomycin as of now. Daptomycin may be used as an alternative. Now then, this is both native valve endocarditis. What if it's an MSSA affecting the prosthetic valves? If it is an MSSA affecting the prosthetic valve, again you have to use either nafcillin, oxacillin, or flucloxacillin as the anti-staphylococcal penicillin. Plus, you will add gentamicin and you add rifampicin. Why do you add rifampicin? Rifampicin is an agent which have activity against biofilms. Now, you know that the prosthetic endocarditis involves biofilm formation. So there you have to use rifampicin to add on the biofilm. So it's a triple combination: nafcillin, oxacillin, or flucloxacillin plus gentamicin plus rifampicin to act on the biofilms. Then you have the MRSA affecting the prosthetic valve. Okay. Here again, you can use Vanco, but what will you add? Gentamicin, you'll add plus rifampicin. So that is the treatment for methicillin sensitive and methicillin resistant Staphylococcus aureus infections. So MSSA, if it's native valve, the treatment will be either cefazolin or flucloxacillin or cefazolin. Okay. If it's a prosthetic valve, you can use flucloxacillin or any other anti-staphylococcal penicillin plus genta plus rifampicin. So this you have to understand. Now, if it's MRSA, if it's a native valve infection due to MRSA, the treatment will be Vanco. And if it's a prosthetic valve endocarditis, it's Vanco plus genta plus rifampicin. So this you have to remember. Now, what if Vanco fails? So Vanco sometimes can fail, therapeutic failure can occur, sometimes the bacteria can become intermediate resistance to Vanco. So where Vanco fails, the treatment of choice becomes daptomycin. This also keep in your mind. So just one example from the infective endocarditis whole topic. There is a lot of important topics that I've already mentioned. Pay attention to the update videos that we have already done. Next important topic is Clostridioides difficile, which is very important. There has been a major change which has occurred in Clostridioides difficile. If you look at the treatment of choice for the initial episode of mild to moderate Clostridioides difficile, so you can see that the treatment option now is mentioned as fidaxomicin is mentioned as first. So this is mild to moderate. So again, you can use oral vancomycin as an alternative. Why is fidaxomicin preferred? Now, fidaxomicin is not an antibiotic available in India. This is just from an MCQ point of view. Now, fidaxomicin is almost equally efficacious as oral vancomycin for the treatment of C. diff. Now, why is it preferred as the initial choice by the US guidelines? It's because it's associated with less recurrence. So the recurrence rate is less with fidaxomicin. Now, if you also look at the second one, if you have an initial episode which is severe, and what is a severe Clostridioides difficile infection? You call it a severe if you have a total count, a leukocytosis more than 15,000, or your creatinine is more than 1.5. If a patient with Clostridioides difficile infection has a total leukocyte count more than 15,000 or a creatinine level more than 1.5, you'll call it a severe disease. Here you can see that the treatment of choice, first option that is given is oral Vanco, and fidaxomicin is given as an alternative here. All right. Now that is important. Now the third one is an initial episode which is fulminant. So what is a fulminant C. diff? Now C. diff, if you have a severe C. diff in association with hypotension, shock, ileus, or toxic megacolon, you call it as a fulminant Clostridium difficile. Hypertension, shock, ileus, or toxic megacolon, it's a fulminant C. diff. And the fulminant C. diff, you have to give high dose vancomycin, 500 milligrams per nasogastric tube. But it is very unlikely that the patient with ileus means there is a no peristalsis. Even if you give a high dose of vancomycin orally, it may not reach the colon. So what do? You add IV metronidazole for whatever action it might have. Plus, you should also consider rectal instillation of vancomycin so that it acts locally. So these are the three important points from that point, part of Clostridium difficile infection. Also remember that, just an MCQ point of view, patient with high risk of recurrent Clostridium difficile who are receiving vancomycin, fidaxomicin, or metronidazole. Okay, along with that, there is an adjuvant therapy to reduce the chance of recurrence, and this is a monoclonal antibody called as bezilotoxumab. Bezilotoxumab, which is given in addition to the antibiotics that are used to treat Clostridium difficile. Now it's called as Clostridioides difficile is a new name. I mean, I can mention I keep on saying Clostridia. The name is Clostridioides difficile. The fifth is the STD table. Now this is a very common question that is often asked. Even the last NEET SS there was a question. So they have given you the incubation period of the various sexually transmitted diseases. In this particular table, this is a very important table. Incubation period, what are the early lesions, number of lesions, the size of the lesions, the edges, the depth, the base, induration, pain, and lymphadenopathy. Now, I'm not going to discuss all of them, but most important will be if you look at syphilis alone, the incubation period is 9 to 90 days. It initially starts as a small papule, which may be even missed. Usually, it's a single lesion for syphilis, but most of the other infections, they can have multiple lesions. It's 5 to 15 millimeters in size. The typical characteristic of a syphilitic ulcer is it's very sharply demarcated, like a punched out ulcer. Okay, it may be superficial or deep. Okay, and what is characteristic is it's a characteristic induration, a cartilaginous consistency that you will get with syphilitic ulcers. Pain is uncommon for syphilitic ulcers. You may get lymphadenopathy. They usually form non-tender bilateral lymph nodes can be seen. Herpes is the other sexually transmitted diseases caused by HSV, usually 2 causes herpes genitalis. Usually occurs 2 to 7 days after the infection. These lesions are vesicles which are multiple, okay, and they are very superficial compared to all other ulcers. And if you look at the pain, they are frequently tender kind of lesions. Chancroid is another sexually transmitted disease which causes ulcers. It initially starts as a pustule. There are multiple lesions, but they may coalesce to form a larger ulcer. It typically has an undermined or ranked kind of edges. So the edges are undermined and racked, and it may have a depth. So there is an excavation which can be seen in case of chancroid. Some kind of a depth is there for the ulcer. So it has a very purulent base which can bleed very easily. It's usually very tender, and it may separate sometimes in case of chancroid. So that is the third one. Lymphogranuloma venereum is another disease caused by chlamydia trachomatis. So it's basically it can occur 3 days to 6 weeks after the contact. The first lesions can be papule, pustule, or vesicle, which may ulcerate, but it's often detected. The ulcer is very inconspicuous. It's not very evident in case of LGV. Most of the time, you may just find the lymph node alone. So it's a superficial, it can be superficial or a deep kind of ulcer. But again, the ulcer is not what is very important. In case of lymphogranuloma venereum, what is important is the lymph node. So there are large lymph nodes which may separate and usually unilateral, and which occurs on both sides of the inguinal lymph node, has large lymph nodes which you call as the groove signs. There is some kind of a groove that occurs along the inguinal ligament. So you call it as a groove sign. So there are lymph nodes on both sides and a groove in between. So the groove sign for LGV. Then you have the donavanosis, again coming around 1 to 4 weeks after the contact, starts as a papule. And what is peculiar is that this kind of an elevated ulcer, elevated kind of ulcer, which is red and velvety and which can bleed very easily. And what is peculiar is that pain is uncommon there, and there is no lymphadenopathy, but there can be what is called as pseudobubos in case of donavanosis. Now, this particular topic of the STD chapter, has been quite often asked, but we often tend to forget it as an important topic. So do pay attention to this particular table actually. One another important topic, I believe, is post-exposure prophylaxis for various bloodborne viruses. There is this table in Harrison that you should always remember. What is the estimated risk of bloodborne pathogen transmission from percutaneous injury? So the most risk, like the maximum risk of transmission, occurs by hepatitis B, that is 30%. For hepatitis C, it is around 3%, and for HIV, it is 0.3%. So it's 30, 3, and 0.3, HBV, HCV, HIV. So the maximum risk is for hepatitis B, then HCV. HIV, the risk is through percutaneous injury is only 0.3. So remember this particular table also. Now, also remember that exposure and the patient is not immune. How do you know the patient is not immune? If it's not vaccinated, and if vaccinated, you look at the anti-HBs titer. If the anti-HBs titer is less than 10, then you think that the patient is non-immune. Here you give the patient hepatitis B immunoglobulin, ideally within 24 hours, or you can give maximum up to 7 days of exposure along with the vaccine, immunoglobulin and along with the vaccine. So that is how you treat as a post-exposure prophylaxis for HPV. HIV exposure, you start the post-exposure prophylaxis within 72 hours. So what is the post-exposure prophylaxis that is currently available? Recommended in India is tenofovir plus lamivudine plus dolutegravir. So this is the current recommended prophylactic regimen for according to NACO. So even if you are doing you don't have a prophylaxis regimen for hepatitis C, you don't use antivirals as for prophylaxis, but you should follow up testing. You can do HIV, hepatitis B, hepatitis V at 6 weeks, 3 months, and 6 months after exposure to know whether your post-exposure prophylaxis has actually worked or not. So that is again, it comes in the chapter of occupational health. I believe it's not very commonly that you go across this chapter, but it's a very, very important topic. Now, infections in organ transplantation, questions can come. I'm just dealing with one table in the hematopoietic stem cell transplant patients. So here there is a timeline of infections where they look at what are the infections that occurs in less than 1 month, what are the infections that occurs at 100 days, and what are the infections that occurs after 100 days. So if you look at the early infections in hematopoietic stem cell transplantation patients, in this early period, these patients are usually neutropenic, and as a result of which they are at risk of various infections, including this includes common bacterial infections, hospital-acquired infections. So this includes the gram-negative as well as gram-positive infections, and Candida and HSV are very important. In the lungs, it can be gram-negative or gram-positive aerobic bacteria, but aspergillus can occur in the initial period of neutropenia. So that is also important. C. diff is very common because many of these patients will be on antibiotic. C. diff is also another important infection. But after that, early infections, that is before 100 days, around 2 to 3 months, you say 2 to 3 months. So what are the common infections? So one of the most common infection which can come as a disseminated infection, it can come and affect the lungs. It can also affect the gastrointestinal tract, is the CMV. So this period, that is from the second month onwards to the third month, that is from 1 month towards 100 days, this particular infection, that is CMV, is very, very important. Can present as a disseminated infection, can affect the lung, can affect the GI tract, or even it can affect the bone marrow, causing bone marrow suppression. This particularly occurs in recipients who are CMV seropositive, but donors who are CMV seronegative. This is in opposite to infection in solid organ transplant. In solid organ transplant, the maximum risk is for recipients who are seronegative, but then the donor is positive. So this is a difference you have to keep in mind regarding CMV. Late infections after hematopoietic stem cell transplant after 100 days, it takes a long time for your immunity to mature, both the humoral immunity as well as the T cell mediated or the cellular immunity. So that is why like you have like encapsulated bacterial infections, which predominantly is like antibody mediated immunity is like deficient. You can get infections due to strep pneumonia, Haemophilus influenza, Neisseria meningitis, etc. And then you have also what is called as like a deficient cell mediated immunity. As a result of which you can get infections like pneumocystis, nocardia, NTM infections, toxoplasma, GC virus, etc. So transplant infections is important, and among the transplant infections, the most important is CMV. So CMV, you have to look at the risk factors. So solid organ transplant, the maximum risk, as I've already told, is for patients who are the recipients who are seronegative and donor who are seropositive. This is an SOT, and if it's HSCT, it's a reverse R plus D minus. So this is one thing regarding CMV. The second thing is regarding CMV is a treatment. What are the options you have? You have ganciclovir, you have valganciclovir, you have foscarnet and cidofovir, and you have maribavir. I'm not going to explain in details, but CMV treatment is important, and the resistant mutations that will confer all these agents are inactive is also important. Also learn about this new molecule, like relatively molecule called as letermovir, used as a prophylaxis. Currently, it is used as a prophylaxis in patients who undergo hematopoietic stem cell transplantation. So that is in both the chapter of HSCT as well as there is a separate chapter in Harrison on CMV. So both has to be like looked at very importantly. This is my favorite. Next one. This is antimicrobial resistant AMR. We have often discussed it in detail. So there are various methods by which the bacteria can become resistant to antibiotics. Those includes enzymes which can inhibits or lyse the antibiotics. The most common example is the beta lactamases. So it can be cephalosporinases, it can be carbapenemases. Okay, so the beta lactamases, the beta lactam antibiotics, as you know, includes the penicillin, the cephalosporins, and the carbapenems. So they are mostly inactivated by beta lactamases. Similarly, there are a lot of mechanisms. For example, is a porin mutations. The porins are the channels through which the antibiotics enters the pre-plasmic space. If the porins are mutated, the antibiotics will not be able to enter. So that is one mechanism. So there is also a mechanism by which the antibiotic may be thrown out of the cell by certain efflux pumps. So the efflux pumps can get overexpressed and the antibiotics may get thrown out. Now there are certain, even if the antibiotics can enter the cell sometimes, there are certain enzymes which can modify the uh, antibiotic. Okay, they will add some group, some phospho group, adenyl group, or something like that, and the antibiotic won't work. The most common example is aminoglycoside. So aminoglycoside modifying enzymes, like they will add a phosphoryl group, adenyl group, or acetyl group, and the aminoglycoside will become, the antibiotic will become inactive and it cannot kill the bacteria. So these are the various mechanisms of resistance, of which like when certain like tables I just want to say are important, but like you'll have to go through the entire table, but just go through the most important. Beta lactam, as I've already told, they act by inhibiting cell wall synthesis. And what is the mechanism of resistance? The most common mechanism is drug inactivation by beta lactam. This is the most important mechanism of resistance. Glycopeptides importance is vancomycin and teicoplanin. So they also inhibit cell wall synthesis, and they bind to a particular part of the stem peptide during the cell wall synthesis. This part is called as the D-ala part. This ala means alanine alanine. Now what happens is the bacteria changes this alanine alanine amino acid sequence to alanine lactate D-alanine, D-lactate, and vancomycin cannot bind. That is how vancomycins become resistant. Now then you have the aminoglycoside, I have already told. Most important mechanism is drug modifying enzyme. Modify the antibiotic so that it cannot act. The second mechanism is methylation at ribosome binding site. So the antibiotics has to act on ribosome. In the ribosome, the site where the antibiotic bind, okay, there is methylation happening, so antibiotic cannot bind. So these are the two important mechanisms by which aminoglycosides become resistant. So the overall, what I have to tell is that this entire topic as such is quite important. Like so the antibiotic agents as well as the various mechanisms of resistance. I'm not going to go in detail, but that is very, very important. So next you have the streptococcal infections. Uh, this is like one table that I want to discuss. Now, the streptococcal infections, you can divide the streptococci into three based upon the hemolysis. Now, there is alpha hemolysis, there is beta hemolysis, and then you have gamma hemolysis. Now, alpha hemolysis refers to a partial hemolysis, beta hemolysis refers to complete hemolysis, and gamma hemolysis refers to no hemolysis. So beta is full hemolysis. Okay, what is hemolysis? If growing the organism in blood culture agar, hemolysis means there is a complete clearance of the red blood cells in the blood agar. So that is beta hemolysis. Alpha hemolysis is partial, and gamma hemolysis is no hemolysis. Now this is like core microbiology, you won't be asked most likely, but among the organisms which has alpha hemolysis, you divide them into further based upon whether the organism is susceptible to a particular antibiotic, and this antibiotic is called as optoshin. If it's optoshin susceptible, okay, there is a clearance around optoshin, Streptococcus pneumoniae. Its optoshin resistance is virulence group streptococci. Don't get too much concerned about this. I'll come to that. Now, among the beta hemolytic streptococci, you can divide them into two groups. One group is called as the group A, also called as Streptococcus pyogenes, if it is sensitive to bacitracin. If it's bacitracin resistance, it's group B or Streptococcus agalactiae. Group B streptococci is also called as Streptococcus agalactiae. Group A streptococci is also called as Streptococcus pyogenes. Both are beta hemolytic, and Streptococcus pyogenes is bacitracin sensitive, whereas Streptococcus agalactiae is not sensitive. Then you have gamma hemolysis. So gamma hemolysis is no hemolysis. If there is no hemolysis, then you can divide them into two. Whether there is a growth in a higher sodium chloride content of 6.5%. If it can grow at more than 6.5 sodium chloride, it is usually enterococci. If it cannot, it's what is called as Streptococcus bovis. And Streptococcus bovis now is commonly, currently it's known as Streptococcus gallolyticus. Streptococcus gallolyticus is the new term for Streptococcus bovis. Okay. Now, if you look at some of these infections, which is given as a table again in Harrison, in the group A, it is Streptococcus pyogenes. It's a beta hemolytic streptococcus, we have already mentioned. It is the commonest cause of pharyngitis. So it's strep throat. It causes impetigo. It's also commonest cause of cellulitis. It can also cause scarlet fever, where you will have a sandpaper kind, erythematous kind of rash occurring. You can have strawberry tongue occurring in these individuals. So then it can also have a toxin-mediated disease called as a toxic shock syndrome, where the patient have a skin infection and the patient go into severe hypertension along with other multi-organ dysfunction. It can also cause a certain immunological manifestations, okay, which in the form of rheumatic fever or post-streptococcal glomerulonephritis. So these are the spectrum of infections that can be caused by group A, beta hemolytic streptococci. Group B, beta hemolytic streptococci, also called as Streptococcus agalactiae, beta hemolytic. What is the common infection it causes? It causes neonatal sepsis and meningitis. So it's a common practice to screen pregnant female for the colonization of the genital tract with group B streptococci. And if they are positive, pregnant females are prophylactically given ampicillin. So the most important infection caused by Strep agalactiae is neonatal sepsis. Okay. Now the group D streptococci, okay, these are the streptococci usually non-hemolytic. Group D are non-hemolytic, fine. And non-hemolytic is also called as gamma hemolysis. Now, there are two organisms, as I already told, based upon their sodium chloride, if they can live or not. Enterococci, which includes two important organisms, Enterococcus faecalis and Enterococcus faecium, that can cause various infections. Faecalis is usually community acquired. It can cause UTI, infective endocarditis, etc. And then there's a non-enterococci. Non-enterococci, I have already told, Streptococcus galolyticus. Previously, it called as Streptococcus bovis. Streptococcus galolyticus is very important. If you have a bacteremia or infective endocarditis due to this pathogen, you have to look for underlying colonic lesions. The colonic lesions can be colonic malignancy, okay, usually, or it can be some polyps, or it can be even benign lesions like diverticulitis. So you have to do a colonoscopy to in every patient who presents with infective endocarditis or bacteremia due to Streptococcus galolyticus. Previously, this bacteria was called as Streptococcus bovis. Now, there is also other variable group which includes the virulent streptococci. In the virulent streptococci, you have Streptococcus sanguis, Streptococcus mitis, etc. These are very common causes of community-acquired infective endocarditis. And overall, now they are being surpassed by Staphylococcus aureus as the most important cause of infective endocarditis, both in the community as well as in the hospital-acquired settings. So that is regarding this particular table. I think this table is sometimes like we may ignore this table, but I feel it has some importance, summarizing the infections due to the streptococci there. Latent TB, I believe, is a very, very important topic. You can be asked about latent TB. One of the updates that I want to give you is that there is a new test that is now being implemented in India. This test is called as a CY-TB. It's like similar to the Mando test. It's an intradermal test. So what do? You intradermally inject certain antigens. So in case of the Mantu, you inject what? You inject the crude tuberculin antigen. It's not very crude, it's a purified protein derivative, but as a whole. But here you are injecting specific molecules. The specific molecule are the ESAT6 and CFP10. Now, if you have read about the IGRA, interferon gamma release assay, these are the antigen used in that test also. There you are doing it in the laboratory and looking whether the monocytes in the macrophages can produce interferon gamma. Here it is different. You are injecting in the skin, ASAT6 and CFP10, and looking whether you can have a Mando-like reaction. If a reaction more than 5 millimeters, you will call it as positive. HIV positive, all age group, everything is same. There's no cutoff differences like Mando. More than 5 millimeter is positive. So that is CFP10. So ESAT6 and CFP10, these antigens are specific to Mycobacterium tuberculosis. It is not there in BCG, and as a result, this is more specific than the MAN2 test. Okay, unlike the MAN2 test, which can form false positive in BCG, this won't be. So this particular test is like now being introduced. Also, now you have to learn about various regimens that are used to treat latent TB infection. Now, latent TB infection is now simply called as TB infection. The term latent may not be there sometimes. So you have to understand that. So TB infection and TB disease. TB disease means the disease is manifesting. Okay. TBI is a new term for LTBI. The term latent may not be there. You may be just asked as tuberculous infection. It's the same as LTBI. So previously we used to use isoniazid as the treatment for treating tuberculosis infection or latent TB infection. For 6 to 9 months, used to give isoniazid alone. There has new regimens has come. One of the new regimen is rifampicin plus isoniazid. Here you give high doses of rifampicin and isoniazid, but they are given weekly. So it's given as a weekly regimen. So this regimen of 900 milligrams of INH and 900 milligrams of rifampicin given weekly is called as a 3HP regimen. Is now considered as a standard regimen. This is being implemented as a favored regimen in India. It's as effective as the 9H regimen, but then you have to give it only for 3 months, that is 12 weeks. There is high rates of treatment completion. Hepatotoxicity is lesser compared to isoniazid alone. Okay, and the rate of permanent discontinuation alone due to an adverse event was higher. So the only thing is that if somebody is discontinuing the drug due to adverse event, that percentage was slightly higher, 4.9% versus 3.7%. So that is some like a demerit that we have observed in the studies. That's all, and it's not recommended in children less than 2 years of age and pregnant females. So that is regarding the 3HP regimen. This is the favored regimen that is now being introduced in India. It's actually equally effective as the 9H regimen. Instead of giving isoniazid for 6 to 9 months, you can just give it for 3 months. Okay, and this is associated with lesser hepatotoxicity and better treatment completion. Well, that completes 10. But I was thinking if we have time, we will have one more. That it's 10 plus 1. Pre-exposure prophylaxis in HIV is a very, very important topic. Now, what is pre-exposure prophylaxis? We all know what is post-exposure prophylaxis. So you give somebody has a, like high-risk contact, so you give them like TLD, like as a post-exposure prophylaxis after the contact. Now, what do you want to prevent it? Like somebody who are know that they are going to be involved in high-risk behaviors. So how do you protect them? So that is pre-exposure prophylaxis, use of antiretroviral drugs to prevent acquisition of HIV in high-risk individuals who are uninfected. So you have the oral PrEP regimen, and the oral PrEP regimen is emtricitabine and tenofovir desoproxil fumarate, TDF plus emtricitabine is the preferred regimen. All right. Now remember that there is no dolutegravir here. Like unlike post-exposure prophylaxis, it's a 3-drug regimen. The pre-exposure PrEP regimen is a 2-drug regimen, tenofovir plus emtricitabine. You can use lamivudine instead of emtricitabine also. So it's taken daily, okay, continuously, as long as there is exposure. So you'll have to start it early and then continue after the exposure, or you can take it on demand also. So there's like 2 to 24 hours prior to your exposure, you can take the drug and then you continue until there is exposure. So there are two kinds of PrEP. There is a continuous PrEP as well as on-demand PrEP, and it is considered as these particular regimens with emtricitabine and tenofovir disoproxil as a pre-exposure prophylaxis is more than 99% efficacious if the patient is adhering. The problem with the PrEP is that many of the time patients won't adhere, they won't take drugs properly, and eventually they may get the disease. Now that is why we are looking for injectable agents. One of the first injectable agent that has been approved is the drug called as cabotegravir, which can be given every 2 months, which has a similar or better efficacy compared to the oral PrEP. But the advantage is that the compliance is better because it has to be taken only 2 monthly. And now we have even better drug, and this drug is called as lenacapavir. It's a new molecule. It's called as an HIV capsid inhibitor. Can be given twice yearly. What does that mean? You have to take an injection. I mean, whoever wants to take an injection can take an injection every 6 monthly and will protect. And it's absolutely like when the result has been very good. Like there has been 100% protection with this particular drug in cisgender females. I mean, so there is also ongoing trials in other group of individuals as well. So lenacapavir is now approved as a pre-exposure prophylaxis agent for preventing HIV acquisition, to prevent HIV acquisition. Okay, so that is regarding HIV. Fungal infections. I just want to discuss a few important image-based questions in fungal infections. So basically, these are histopathology. Anybody want to answer these questions? Can answer. So what is this? What is this particular disease? Like, I'll check if somebody is answering. Fine. So if you look at like anyway, it's fine. Like these are image-based questions. Like so, this what is this fungi? Now, there are two fungi that you need to differentiate. If you look at this fungi, these fungal infections, like there's a histopathology of a particular fungus. So these are thin septate fungi. Okay, they are thin septate filamentous fungi, or called as molds. Thin septate mold, and they branch at acute angles. So this is a typical appearance that you get for aspergillus. Okay, aspergillus. So they are thin, they are septate, and they branch at acute angles. The color may vary because this is a hematoxylin eosin stain. Sometimes you may get a black. That just means that they have stained with the silver stain like gomorimethylene and silver. So don't look at the color and identify organism. You look at whether it is slender. You can see they are slender. Look at the branching. If you look at the branching, where is the branching? You can see, yeah, there is a branching here. So they branch at acute angles. Branching at acute angles. Thin septate. So the septations, you can see the septations in all of these uh, fungal filaments. So that is the typical appearance of aspergillus. Now come to the next one. This is mucormycosis. So what is the difference? They are broad, ribbon-like, okay, broad ribbon-like structures. The hyphae are broad and ribbon-shaped, and look at the angle of branching is 90 degrees. So it's the typical appearance of mucormycosis. These are the most important mold infections. The mold means they are filamentous fungi. So differentiation between aspergillus as well as mucormycosis. Now coming to the yeast cells, you can get yeast also as a histopathological appearance. So this is a typical appearance. You can see there are a lot of macrophages, and yeast has, like, when they are spherical structures. So spherical structures, they have a nucleus inside it. So there's a typical appearance of a yeast. Now this can be very closely confused with the kind of, like, what is called as visceral leishmaniasis, where you have LD bodies. So LD bodies, the appearance is very similar. So they will have a spherical structure, they will have a nucleus, but in addition to the nucleus, they will also have what is called as a kinetoplast. Kinetoplast. So this is the LD bodies or the amasticote form of visceral leishmaniasis or Leishmania donovan. So remember this. So the yeast form here that you see here is that of histoplasmosis. Histoplasmosis. So histoplasmosis, this is a typical appearance. You can see there is a biphasic staining. So there is staining in one part of the cell and you have a very characteristic nucleus there, but there is no kinetoplasm for histoplasma. Whereas for visceral leishmaniasis, you will see a kinetoplasm. So that is the difference between histoplasmosis as well as visceral leishmaniasis. Now there are other yeast also. Now Candida is also in yeast, then other yeast also. Now this is not very easy, but this is another yeast. You can see, if you look at this yeast has a septation. But this particular infection occurs as an opportunistic infection like histoplasma. This is endemic to northeastern part of India as well as other countries. Okay, and this infection is the reservoir of this infection is the bamboo rat. So anybody know the answer? Septate yeast, northeastern India, bamboo rat. So the disease is called as Talaromyces marneffi. It was previously called as Penicillium marneffi. Now it is called as Talaromyces marneffi. So septate yeast can cause disseminated infections as well as cutaneous lesions similar to histoplasmosis. Endemic in northeastern India. Bamboo rats are considered as the reservoirs of this infection. Now, the final image, sometimes what you can get in fungal infection is this brown lesion looking like a copper coin. They're called as copper penny bodies. They are also called as medullary bodies. This occurs in a subcutaneous fungal infection, okay, which occurs commonly after trauma, especially in farmers and all. They present like verrucous lesions, cauliflower-like lesions in the lower limb. and the disease is called as chromoblastomycosis. So you get what is called as the copper penny bodies. So that is just like few, like most important histological questions that you can get from the fungal infections. I think I'll stop with that. That is 10 plus 2 important topics. Like as I have already told, unfortunately, this won't cover everything in infectious diseases. There are many left actually, but these are some of the points that is like important. Like I believe can be asked, maybe asked, or surrounding questions from this also. We have discussed in details the updates in all the chapters, including parasitology, which I have missed in this. Uh, Including malaria treatment, which all are important. The parasitology, like though I have not discussed over here, malaria is evergreen kind of topic. Like you can be aware, like you can ask any times. We have discussed many times how to differentiate between species, so that can be an image-based question that you have to know. You should also know the difference between complicated and uncomplicated malaria, and what is the treatment, and what are the species which needs treatment to prevent a relapse. So prevent relapse, you have to treat Plasmodium vivax as well as Plasmodium ovale. And for treatment of the relapse, preventing relapse, you can give primaquine for 14 days. And you have a newer molecule which you have discussed in the update session, tafenoquine, given as a single dose, not available in India. So these are important. The rapid diagnostic test of malaria is also important. Also remember that there has been a change in the first trimester pregnancy. They now recommend artemether lumefantrine for uncomplicated malaria. Artemether lumefantrine. So I think we will stop with this. So these are like some of the important points that can be asked for both the exams, NEET SS as well as the exams. Detailed videos are available in the app. We also have videos specifically on the tables and figures in Harrison. Also, you have a separate video on the updates of the 22nd edition of Harrison. Hope you will be seeing that, and all the best for all your exams. Thank you. I'll see if I get any questions. Can't see any questions as such. So, guys, signing out.